Hi, everybody. Just wanted to get lectures posted for the second portion of musculoskeletal injuries. And then I'll touch base on our lupus and then like Raynaud's. And then there's another section too that I think I'm going to actually post it in a separate video. Um, Let me go ahead and share. We'll get going with this. I know you guys are probably about had it with listening to me over the course of the semester with all these lectures. So I'll try to go through it pretty quick and concisely. Musculoskeletal conditions, I'm sure you probably have seen it already, but they're pretty much like one of the top reasons that people seek out care in terms of primary care, urgent care. So you will definitely be managing a lot of different musculoskeletal injuries or conditions. Very, very common. So through each section, I have like a general overview, like the ankle and foot pain. Obviously, you can have different types of issues, whether it's like a tendonitis or a sprain, or more arthritic changes or things like Achilles tendinopathy. And really, it's just taking a good history of when it started, what exacerbated it, those typical signs and symptoms, and that history that you want to kind of delve into with that with your patient. Achilles tendonitis can be very common. Obviously, if there's tightness there, a lot of times actually ortho will put them in a boot at night, and it's actually to stretch out that tendon essentially there. But sometimes they're at risk for tendon rupture if it's gone on too long and it's too tight, and they do something and they can actually have a rupture. Um, Plantar fasciitis is super common. I'll go through that like in another slide, but a lot of times they complain of pain with weight bearing. Usually it's more common first thing in the morning because after you sleep, your foot relaxes and then those muscles and ligaments actually kind of like contract in. And then when you stand up and put weight on it, it spreads it back out. And then that's why they have pain like that in the morning or after periods of rest. Different diagnostic testing for MS issues is it goes everywhere from X-rays to ultrasounds to MRIs to CT scans, and I'll kind of go through that through each separate diagnosis. In terms of management, a lot of them see management principles: RICE, which is right, rest, ice, compression, elevation. Weight reduction is a big critical thing to talk with patients. And I think I've mentioned it with like low back pain or chronic low back pain. Same thing with knee, hip, foot, ankle issues. The heavier the patient is, the more weight or pressure is put on that joint, and more likely they are to have issues or arthritic changes or even tears. NSAIDs are a staple that we use a lot for MS issues. If they tolerate it, you have to really look at your patient's history because remember, you have to be very careful with NSAIDs and those patients that have a cardiovascular history, kidney disease, etc. Stomach is another big one. History of ulcers and things like that, you got to watch with your patients. And that's when you would go to like COX-2 inhibitor. If it's one joint, I know I mentioned it before, I use a lot of Voltaren. It's indicated for the knee, but I do honestly use it elsewhere. Orthotics, night splints, we'll talk about that. Immobilization, depending on what's going on. PT is a big staple too. And obviously orthopedic referrals, another area that you definitely have to think about. So with plantar fasciitis, usually they'll have more of a sharp stabbing pain that they feel at the bottom of the foot towards the heel. And a lot of times it does radiate along that arch. First steps in the morning tend to be the most painful, or after prolonged rest, they tend to have more pain. Improves with activity, but if they overdo it, they actually start to get more pain with it again at that point as well, or it gets flared up. It does have a gradual onset over weeks to months, and it can be linked to any new activity. So you want to inquire about that. Is there something that they're doing differently in terms of exercises or sports? Another huge one is shoes or new footwear. A lot of times it's the shoes that they're wearing that are contributing to the development or exacerbation of it. Other risk factors, you can go ahead and read these. Flat feet or high arches, either one or the other of the end of the spectrum, essentially can contribute to it as well. A tight Achilles tendon or calf muscles is a big cause of mid-foot pain too. That's another thing to recognize because it's all interconnected. So if you have a tight Achilles, then they are more apt to having mid-foot pain because of that. Footwear is a critical factor that you have to really look at in terms of their shoes that they're wearing and if they're wearing them for too long. So they tend to have point tenderness around that the calcaneal tuberosity, right where that plantar fascia basically connects. So if you were to palpate in that area, sometimes they'll complain of pain. With range of motion, you want to assess like the ankle for dorsiflexion. You want to look for tightness of that Achilles tendon, because once again, that all feeds into foot issues as well. There is a test called the windlass test. It's when the toes are dorsiflexed, it stretches that plantar fascia, so they have pain on that essentially. And then really look at your patient's gait. And I kind of mentioned this before, whether it's their knees, their hips, their back, look at their gait. You can reveal a lot just by looking at the way that they walk or some of the compensatory mechanisms that they do due to pain. Um, in general, imaging may not necessarily be required. It's kind of a decision that you make with your patient, and obviously if there's any red flags there or the severity of it or the length of duration of how long they've had it, obviously then you're going to move into doing x-rays. In general, we usually start with x-rays because you want to look and see if there's anything like bone spurs, any fractures. Some patients can actually have stress fractures. Those are more common in those that are very active runners, those that participate in sports. Sometimes you'll see stress fractures as well. So you want to rule out other causes of heel pain, of course, if you're unsure or if you're not making any progress in terms of treatments. Ultrasound or MRI, this looks more at the soft tissue. So if you are looking for anything like tears or thickening of that fascia or any other conditions like any nerve issues in the foot, because people get neuromas in the foot, you can also order an ultrasound or an MRI. Usually you go with an MRI. That's typically the next one that you move to. First line is obviously conservative management and it's lifestyle modifications. So it's things like rest, avoiding those activities that are making pain worse, like prolonged standing, running. The big thing, like I said, is looking at their footwear, ice therapy. So using a frozen water bottle on that heel for 15 to 20 minutes, several times a day. Actually rolling their foot out on a can or that water bottle actually helps too, because it actually kind of loosens up that fascia in that area. So that's another good suggestion that I always have my patients do too. Stretching their calves is a big one. So making sure that they don't have tight calves and Achilles tendon, essentially, because that's just pulling more on that midfoot. Weight management's a big one. Strengthening exercises. In terms of like stretching it, you can actually have them use a towel and pull, basically wrap the towel around the ball of the foot, and they pull it forward towards the shin, and it actually will stretch the arch of the foot. Rolling, it's another big one that I already mentioned. Toe curling, like you can have them grab a towel with their toes to pick up objects, and it actually will strengthen some of those other intrinsic foot muscles as well. So it takes the pressure off that plantar fascia. Orthotics is another one. You can have them use heel cups or heel pads. Those are good too. Obviously, you can refer to ortho or even a podiatrist too if you need them have custom orthotics made as well. NSAIDs, in terms of meds, usually we use like ibuprofen and naproxen like 500 milligrams twice a day. Make sure that they're eating with it though, because of the GI upset, and it can cause obviously gastritis or gastric ulcers. If they are at heightened risk for that, then you want to use like a COX-2 inhibitor like Mobic or Celebrex. Diclofenac gel or Voltaren is another good option that is useful, and they can put that on a couple times a day. Other advanced interventions, and usually this is when you would refer, obviously, if you're not making much progress with the conservative therapy, then you're referring either to podiatrist or ortho. Ortho will do things like steroid injections. We don't try to do too many steroid injections because it's actually not that great for the joint and tendons. Over time, it can actually cause more degenerative changes to the joint. and it's not that great in the end for even like their tendons and ligaments and all that. But so we definitely will use it in points of refractory pain or where we can't get it calmed down. But we really try to limit it in terms of frequency and the amount of times that that joint or area is injected, essentially. PRP is another injection, and it's actually platelet-rich plasma. So we're actually spinning down the patient's whole blood to get the platelets, and it basically stimulates growth or has growth factors in it that basically will promote healing in the area. A lot of insurance companies will not pay for that, though. So it's kind of some patients are willing to pay for it. It's just kind of one of those options that are kind of a end result that like or last line result that you would go to. Shockwave therapy, that's more in chronic cases. Obviously, surgical options, it's very rare for this, but they can actually do a fascial release. And this is really if it's only severe pain and it's after like 6 to 12 months of failed conservative management. If the patient does have heel spurs, though, they may more likely be a candidate for surgical intervention. Obviously, because a heel spur is not going away, very difficult to treat other than surgical removal. So that's something that if it's that problematic to your patient and they have a lot of heel pain, you note it on x-ray, then that's something that they may need to explore as well. So these are just key takeaways. Most conservative treatment usually works within 6 to 12 months. Look at footwear, stretching, healthy weight. And then obviously escalation to advanced therapies is rare, but maybe necessary for more severe cases. Bursitis is the next one. It's actually very common. You'll see bursitis a lot in the knee, a lot in the hip. The hip, you see it a lot. And the elbow. The elbow, you'll see it as another area as well. It's an inflammatory disorder of the bursa, and it can be acute or insidious. Like, so sometimes it comes on slowly, and then sometimes they actually get flare-ups of it. Like they'll have it, and then once they kind of get this underlying inflammation of the bursa, they're just more apt to keep getting bursitis in that area as well. It may result in mild pain or be quite disabling. So sometimes it's severe pain that they notice. Like with the hip, sometimes they can't even lay on that side of the hip or they have a difficult time with range of motion. In terms of your exam, you really want to look at active and passive range of motion and look and see if there's any deficits there in terms of neuromuscular deficits as well. In terms of diagnostics, x-rays are usually our first go-to. Second would be ultrasound, then MRI. Usually, like I said kind of even before, we tend to usually go to MRI after x-ray. But you definitely have to start with an x-ray to look at the bone structure there to see if there's anything else going on. And usually insurance won't cover an MRI until you get that x-ray as well. If it's indicated, if you know other systemic symptoms or they show signs of a possible rheumatologic disorder, that's when you want to look into some of those other blood work values like an ANA, a rheumatoid factor, a SED rate, CBC, like if you're suspicious of like an infection. And if the bursa was ever drained, like usually in primary care, they don't do that. Usually ortho's the one that drains bursa. And unfortunately, a lot of times they reaccumulate, but sometimes they'll culture whatever aspirate that we get off in terms of aspiration and then send it to the lab. Because sometimes it could show indications of infection. Like sometimes you'll see that with the elbow, just because of basically you could have a small, tiny abrasion right where the bursa is, and it gets infected easily. So really what it is, it's basically inflammation of the bursa, that fluid-filled sac that actually is the mechanism or the normal mechanism of it is to reduce friction between tissues, between like the muscles, tendons, bones, etc. And it occurs a lot in areas where they're subject to repetitive motion or pressure. So that's why you see it a lot in the hip. It's the constant flexion of the hip. The elbow, the same thing. You see it a lot in the elbow because of the constant flexion of the elbow, or you see it a lot because people rest their elbows on their desk or their car. So you'll see it in those two areas fairly frequently. So it's usually areas of pressure and then a lot of friction in that area as well. So with the hip, because the two that you'll see, like I already mentioned, the hip is one of the biggest ones. The bursa basically is overlying the greater trochanter of the femur. So a lot of times they actually will complain of tenderness in that area. They have a difficult time laying on that hip. It may radiate to like their thigh or buttock area. But one of the big symptoms I would say is when they lie on that side, their hip will ache. If they have prolonged standing, that's when it starts to get flared up as well. Activities like walking and climbing stairs will actually exacerbate it, or they feel more pain with it. And generally, they'll have tenderness over that lateral hip as well. It may feel stiff. So that's a question you always want to ask. Do you feel a lot of stiffness in that hip? Is it after inactivity, or is it worse with activity, morning versus night, etc.? When does it wake them up at night? Things like that are questions that you want to inquire about. So point tenderness, I already mentioned. They may have pain upon palpation that may be worse when you do active or passive range of motion with that hip. In terms of imaging, if it's necessary, obviously you start with an x-ray, because you want to look at other causes too, like do they have general arthritis in that hip? Because if they have degenerative joint disease there, or they're bone on bone in the hip, that's a quite different story than bursitis. And you do treat with anti-inflammatories, but there's obviously with bursitis, it's more of an acute issue that you can treat and get calmed down versus an arthritic change there, which is chronic. The next step generally was we would move to an MRI to look at for inflammation, any tendinopathy in the area, and that would actually show too if the bursa was enlarged, if there was a lot of fluid around it as well. In terms of treatments, it's lifestyle modification. So it's rest and then avoiding aggravating activities, making sure that they're using cushioning. I like padded chairs, like as if sitting is aggravating their condition. Going up and down the stairs a lot. Sometimes it's hard for them to limit that, but it's important to educate them on it just so that they can do like planned trips upstairs if they, like if they're an older adult, whether it's arthritis or not. It's just talking to them about things like that that aggravate it. In terms of meds, again, we use NSAIDs for pain and inflammation. You can also use topical analgesics as an alternative. Going back to NSAIDs, I already mentioned, I use a lot of like Celebrex and Mobic because it is gentler on the stomach, and a lot of patients with these musculoskeletal conditions are already older, or generally tend to be older, so you have to be careful with that. PT is another big thing that works too. Physical therapy is one of those tools in your back pocket that you'll utilize a lot. Because really it's about stretching and strengthening a lot of the muscles and stretching the tendons and ligaments around the joint as well. So if you strengthen the joint, it takes the pressure off of the actual, I shouldn't have said strengthen the joint. If you strengthen the muscles around the joint, it takes the pressure off of the actual bony structure there. And then it helps relieve that as well. And obviously, too, another big thing is IT band stretches. IT band problems are very, very common too. And sometimes that presents as hip pain or knee pain because that's where it connects your hip or your knee from your hip to your knee. So sometimes working on that IT band and releasing that IT band through PT is definitely beneficial as well because that is commonly tight in a lot of individuals. And then it causes knee pain or hip pain in patients. Steroid injections are more for those persistent cases. Obviously, I would be referring them to ortho for that. Surgical interventions like removal of the bursa is very, very rare. And that's really only in those refractory cases, essentially. Same thing with the elbow. So this is the other one that you commonly see it in, Urgrnt bursitis. And it's basically right at the back of the elbow. And a lot of times with this one, you will actually see visible or palpable swelling over that, over the elbow joint. And it may feel pretty significant, like it might feel pretty enlarged, and it actually shouldn't feel super hard. It should feel somewhat soft, but it's usually tender to the touch. It usually worsens with pressure on the elbow. So like if they lean on their desk or they're driving, they complain that their elbow hurts a lot. And they tend to get flare-ups of it. It'll go away, kind of that waxing and waning thing. And they really just got to continue to eliminate those things that aggravate it, essentially. You do want to assess for any redness, warmth, or like very significant pain, any symptoms of infection, because you can get septic bursitis, which, like I mentioned previously, the elbow is more likely to get that just because of friction on the elbow, and a tiny, tiny little opening can get bacteria in there and can cause infection of the bursa. Obviously, that's an immediate referral to ortho. For surgical interventions, they clean it out. And then obviously, too, they're going to get IV antibiotics because you're at heightened risk for osteomyelitis as well. Um, Restricted motion, it's rare unless associated with severe inflammation infection. So they usually have normal range of motion there. It's just they have this very painful elbow that when you feel it, you palpate on it, it'll be painful. So history and physical exam, same kind of concept, like I already mentioned with the hip. You want to really look at what they're doing, look for systemic conditions. Do they have anything else going on? The big thing with the elbow too is you got to think about gout or RA in the back of your mind. Gout, I would say more likely because sometimes it does present that way where they get these tender like smaller joints like that swelled up with gout. You'll see that besides the big toe. Um, Look for signs of infection. Always do this: fever, warmth, erythema. Other diagnostic tests, if usually this would be indicated for ortho. So if your patient requires aspiration, you should be referring them. So that's if it's suspected infection. If it looks like they have septic arthritis, then you need to send them to the ED. You can do X-rays to rule any fractures or underlying joint conditions. But again, if you note anything in terms of like a rheumatologic finding or septic arthritis, or anything that looks suspicious of a tear, then you want to make sure you're referring to ortho or rheum. So again, it's rest, avoiding aggravating activities, NSAIDs. You can do compression wraps to reduce swelling. They can move to like aspiration or steroid injections for persistent inflammation of the joint. Infectious bursitis, that would be managed by ortho. And then antibiotics are determined based on culture and sensitivity. They usually drain it, and that sometimes repeat aspiration needs to be done if it reaccumulates again. This is just a table I added and I put together like the differences between hip and elbow. Like the one big thing, like I mentioned before, is that the elbow bursitis is more, it has a higher risk of infection versus the hip. A lot of the same principles apply, like NSAIDs, steroid injections. With the elbow, you do tend to do more aspiration. You aren't going to do aspiration with the hip. And then just general signs and symptoms that you'll see. Hip pain. So another issue with hip pain besides bursitis of the hip, a lot of times it's osteoarthritis. So it can be a more chronic issue or be more acute with a traumatic injury to the area. Do they have a fall? Those are things you want to ask about, obviously, too. What precipitated the event? What's making it worse? What makes it better? How long has this been going on? Have they had problems with it previously? So obviously you got to do a thorough exam, whether it's inspection, palpation, range of motion, whether that's active or passive, and looking at strength and stability of the joint, and then their gait. Like I mentioned before, gait is critical. You can tell a lot by the way the patient walks. Sometimes you'll see them limping a little bit with it as well. Diagnostic studies, I kind of already went through this. X-ray, that's usually where you start. Then you move to an MRI. If you're suspicious of other things going on, a CBC, a SED rate, CRP, RA panel. So basically a panel to look to make sure it's not anything rheumatologic going on, or even a uric acid if you are considering gouty arthritis as well. Nerve conduction studies, that's another thing, like an EMG. If you are unsure of where the pain is actually originating, because sometimes patients will present with hip pain or even groin pain that may be originating from the spine and not necessarily from the hip. So you really got to do a thorough history on not only the hip pain, but also in question about their back, Do they have any issues with their low back? Do they have issues with their sacroiliac joints? Do they have pain in the buttock area? Kind of try to figure out where that location is and delve into the history to determine whether it's actually coming from the hip. However, if you are suspicious of something like that, a good test to do is an EMG because it will tell you the nerve root that it's actually coming from, or if it's a peripheral nerve that is causing the pain as well. So obviously management is treating the underlying problem, whether it's osteoarthritis, bursitis, IT band issues, things like that. And then most times the same thing like NSAIDs, physical therapy, exercise, pain management, and then surgical consultation if needed. So again, it's common and it could be related to something local or a systemic condition. So you really want to take a systematic approach, including a detailed history, a physical exam, and then obviously imaging and lab tests. So some different characteristics in terms of pain, you really want to get them to describe it. Where do they feel the pain? Is it burning? Is it aching? Do they get shooting pains? Things like that. In terms of location, if it's more towards the anterior groin pain, it's usually more suggestive of an intra-articular pathology like an osteoarthritis or a labral tear. Lateral pain, it's usually more of that bursitis. So if it's more right on that side, it's usually bursitis. If it's more groin pain, it tends to be more osteoarthritis. If it's posterior, then you really start thinking, okay, is it their SI joint? Because your SI joint can cause issues too. They can have sacroiliitis or SI joint dysfunction there, or even pain from the lumbar spine. So really trying to locate that pain, whether it's anterior, lateral, or posterior is helpful as well. And then looking at onset, was it sudden? Did they have any type of trauma? Did they fall? Because obviously that leads you towards more of like a fracture, potential fracture. Is it gradual? Gradual is usually more of an arthritic change or overuse injuries as well. And I think I mentioned this before in terms of looking at different disease states, like we label chronic usually greater than like that 3 month mark. So acute's like less than 4 weeks, subacute's like that 4 to 12 weeks, and then chronic's like 12 weeks. So you can kind of bracket them out into like, um, weeks, and so forth. Like obviously with arthritis, you're going to be going into more of that chronic issue, versus a fracture is acute and it would be a quick onset. So you want to inquire about aggravating factors, relieving factors. Is it worse with weight bearing, or running, walking, etc.? Is there pain at rest or at night? That's a little bit more worrisome when you're thinking about rest pain, with like malignancy or an infection going on. But a lot of times too, kind of like how we talked about like inflammatory back pain, they have more pain at night or at rest, because it's an inflammatory process. And then usually when they're not active, it's actually when it flares up more. Look at associated symptoms. Is there any stiffness associated there? Do they have clicking or locking? You might see that with a labral tear of the hip. Same thing with the knee. Like if you get clicking and locking, a lot of times it's related to like a meniscal tear. And we'll get into that when we get to knee. But so ask about that. Like, do they have stiffness? Do they feel any clicking, locking? Is there any numbness or tingling or radiating pain? Because if there's numbness or radiating pain, then you're potentially need to start looking at like a sciatica or referred pain. Is it coming from the back, essentially, the spine, instead of actually being the hip? So these are just risk factors: trauma, overuse, systemic conditions. And then if you look at age and you kind of bracket it out by age, young adults, they're more apt to things like stress fractures. You'll see that a lot with like high impact activities or those that are very physically active. Same thing with labral tears, hip dysplasia too in the younger adult. Middle age, that's when you start to see osteoarthritis coming on too, or impingement syndromes with that too. Older adults, obviously, you really definitely start to see osteoarthritis, and then fractures can be present as well. So look at their gait, look and see if they're limping, look for any swelling, redness, deformity around the hip. Sometimes you'll too, and this goes with like even the shoulders or The knee, you'll see actual atrophy of the muscles around that joint. Like the quads, let's say it's the knee or the hip, like sometimes the quads will be atrophied on that side because they're not using that leg as much. Same thing with the shoulder. Like you'll notice that the pectoralis muscles are atrophy because they're not using their arm as much. So really compare and contrast both sides of the patient's body and look at their musculature as well. Feel for bony tenderness over like landmarks like the greater trochanter, because you could have bursitis. Um, Look for soft tissue tenderness like the hip flexors, abductors, do active and passive range of motion. If they have very painful limit of motion, it's more related to like an intra-articular pathology. And then there's Faber test, which actually is flexion, abduction, and then external rotation. And it's more suggestive of like an intra-articular or SI joint pathology if that's painful, essentially, upon exam. Diagnostic studies, again, X-ray, MRI, ultrasound, CT. So it's usually X-ray, MRI. Those are the two that you generally always get an X-ray, and you always want to do an AP lateral, because you obviously want views from both sides to get a good image of the joint. And it's the first line imaging that we use to look for arthritic changes, fractures, or structural abnormalities. MRIs are good if you're looking things like tears, tendinopathies, even bursitis. It can detect like smaller stress fractures or avascular necrosis. So if you're not getting a good result with your X-ray and you need secondary imaging to pick up on other more minute details or soft tissue details, that's when you move to MRI. Ultrasounds are used here and there, and that's more for like if you're just assessing like the bursa, like for bursitis. Some orthos actually use like, and where I practice, we use ultrasound a lot. Like we would use it in the office to actually look for tears. But obviously you have to be skilled in reading them and being able to identify a tear on ultrasound. So in general, in primary care, you're really going to be using X-rays and MRIs. Lab tests, it's the same kind of things that I've mentioned before. Like you really got to think about other systemic conditions. Is there something else going on? Do they have other systemic complaints like fatigue, other joint pain? Do they feel worse in the morning and then they feel better with activity? Like think about those things too. Do they have a history of gout? So really kind of look at it holistically and look at their past medical history to make sure that it's not associated with what they're presenting with. These are just differentials that you can think about, and kind of by location, like I already mentioned with like anterior hip pain versus lateral versus posterior hip pain. And it's a lot of the same ones that I kind of went through before. Like IT band syndrome is another one that's very common that you'll see. SI joint dysfunction is very common. You'll see that. Obviously, lumbar spine pathology is super common, and it can present with hip pain. Labral tears are common. So those are pretty much the big ones, and osteoarthritis, obviously. So look for red flags. Any severe sudden pain after a trauma. Obviously, in this case, you're suspicious of a fracture or dislocation in the patient. Any onset of fevers, chills, night pain. You're worried about potential infection or malignancy there. And then that's the other thing, think about their past medical history in terms of any cancer previously, because obviously we worry about bone mets too. Any neuro symptoms, so always inquire about numbness, weakness, tingling, things like that, because that indicates more of a neuropathologic condition. So like something like a radiculopathy or nerve compression, whether it's a peripheral nerve or coming from the spine. In terms of overview of management, again, it's a lot of the same things. It's rest, ice, NSAIDs, therapy. Can do things like steroid injections for bursitis. And sometimes they do it for osteoarthritis too. Like we use a lot of steroid injections for osteoarthritis too. But like, again, it's not great for the joints. So in the long run, we do limit the amount of injections that we give. Surgical approaches, obviously, for fractures, or if they have severe arthritis, like if they need a total joint replacement, or like even the knee, you'll do partials. Refractory labral tears that don't respond to like therapy or conservative treatment. That's another one that will be a surgical approach. And obviously, at this point in time, you're referring them to ortho for further plan development, essentially. Knee pain is super common. So a lot of these have. Sorry, I just got interrupted. Okay, so knee pain is another very common one. It's probably more common than any of the other ones besides the spine. And a lot of it's just obviously because of overuse of the knees and the anatomy and the function of our knees. So it can be a lot of different issues, whether it's osteoarthritis, or it could be meniscal tears, or it could be derangement of the ligaments inside the knee, like an ACL, MCL. Um, so there's a multitude of different injuries that can occur to knees. And you really got to look at it again, whether it's like an acute onset versus a chronic. So chronic would be more of like your osteoarthritis, where acute is something more related to like an ACL, MCL, or even meniscus tear as well. So we'll kind of go through these as we move through. ACLs, usually these patients, obviously, they'll know like when it happens. They usually hear a pop. A lot of times it could be like they get hit from the side of the knee, or they do a quick turn and then or a quick pivot, and then that's when they'll tear their ACL. But usually with this, their joint's completely unstable because that's what's anchoring the joint, essentially, the bony structure there. So another big thing with injuries like an ACL or an MCL, they end up with significant swelling within a few hours of injury. So within a matter of an hour, 2 hours, their knee just blows up. So a lot of times with an acute injury, a joint effusion will be present. They'll have tenderness along that joint line, and they obviously generally will feel like their knee is unstable, essentially. And depending on how significant the tear is, the more stable versus unstable it may be, because it could even be a partial tear that they still have some level of stability there. So you assess range of motion, their gait, joint stability, and then obviously appropriate knee exams, which I'll go through in a minute. Diagnostics, in terms of the first imaging test that you'll do, even though it does seem like it would be something like if you were suspicious of an ACL, you're still going to get an x-ray on that patient. You're still starting with an x-ray, but obviously to assess an ACL, MCL, the even LCL, things like that, or meniscus, you have to get an MRI on the patient. In terms of management, again, rice, pharmacotherapy, NSAIDs, acetaminophen, you can have them alternate between the two for pain management. Obviously, if it's severe enough and it's a surgical case, they may need even like opioid therapy as well. And then if it's a tear, they need surgical intervention, whether it's a tear of the meniscus. And some of those heal, so not all the time. It just depends on how severe it is. But if they have an ACL tear, they'll require surgery. And then obviously too, with like other chronic changes like osteoarthritis, it could be things like scopes that are done to kind of clean up some of that cartilage in there, or they go all the way to like a partial knee replacement to a full knee replacement. Big thing obviously is PT, OT, crutches, walkers, immobilizer. Like, so even like those patients that had a previous ACL tear and MCL tear, and they're very active and they're in sports, a lot of times they'll be put in an immobilizer just to kind of help protect that knee, because a lot of times their knee is still weak afterwards. Immediate referrals obviously indicated if you are suspicious of any tears, any fractures, if they have knee locking or catching, or any obvious like dislocation that you note there, or a significant effusion, you definitely want to get them sent on to ortho. So this is just kind of like I already mentioned, going through the onset. Is it acute? Is it chronic? Because that will differentiate with in terms of presentations. If they have anterior knee pain, sometimes it's what we call patellofemoral pain syndrome. They could have quadriceps tendinopathy. They could have bursitis. If it's medial, it could be an MCL tear. Medial meniscus, which is super common because actually that's usually because of the anatomy. of our knees and the way that we typically stand. The medial meniscus is usually the one that gets torn versus the lateral. But meniscal tears are super common, and you see that a lot, like with a lot of overuse, or you see it as patients get osteoarthritis. They get fraying of the cartilage in there and like middle meniscus tears. Usually those are they're treatable by scope. Typically they'll go in by scope and actually clean those areas out. Lateral collateral ligament, that's the same type of thing, but on the outside of the knee, just like an MCL, but it's your LCL. You kind of have a lateral meniscus tear. IT band syndrome is super common. So that's another thing like they have where the IT band inserts there and at the hip. Patients will either present with hip pain or knee pain. So IT band syndrome is very common. Um, and although it's very painful, but usually rolling out the IT band with like a foam roller is actually very helpful for patients and making sure that they're stretching it too. But IT band syndrome is pretty common. Baker's cyst is another thing that you'll see, and it's a popliteal cyst, so the fluid accumulates in that back portion of the knee, and it's related to some sort of derangement or fluid collection within the knee, and then it collects in the back. So even though there's a cyst in the back, it's usually from an internal structural issue, essentially, that causes the Baker's cyst to accumulate, essentially. So there's something going on within the knee. So if there is a Baker's cyst, the patient needs imaging, first X-ray, then usually MRI to look at other issues like any tears. PCL is another one that they'll present with posterior pain. And they do have instability with that as well. Not necessarily as much as ACL, but they do have instability with that as well. So determine the quality of pain. Is it sharp? Is it localized? Is it just like, do they have pain just sitting there, or does it hurt when they just walk? Is it achy? Because it kind of helps you differentiate. Like a meniscal pain is more of sharp, localized pain. Like they'll point to like the outside or inside of their knee and say it hurts like right there when I walk. And that's usually more of like a meniscal type injury, or they say it catches. If it's more dull, achy, where they just ache, it's usually more of like an arthritic change, like general arthritis there. The big thing is looking for swelling or effusion. We call them effusion. And you can actually typically, if you, number one, compare joints, look at both knees because you'll see the difference there. You'll see one, because you wouldn't really necessarily notice it until you look at both legs. And you can actually palpate it and feel it. Like the kneecap will actually kind of bobble a tiny bit. It's hard to describe, but you'll feel it when you feel like the actual around the knee and just above the patella. Essentially, you'll be able to tell. Asking about any locking or catching. Does it feel like it's giving way? Because that's usually when you have more of like those ligament injuries. Do they have stiffness or decreased range of motion? That's more related to arthritic changes. What makes it worse? What makes it better? Look at the risk factors. Do they have any repetitive strains, repetitive trauma, like sports participation? It's a big one. Like, what do they do in terms of activity? Are they runners? Like things like that they do over time. Obviously, although it's great for you, it does put wear and tear on your joints. Or whether they play soccer or hockey, whatever it may be. And then inquire about systemic conditions too, like do they have a history of RA, gout, any previous joint infections or anything like that too. Obesity and poor biomechanics. Ask what they do for work too, because that's another big thing. A lot of times what they do for work contributes to musculoskeletal injuries as well. I kind of already went through this, so you can read through this, but this is like swelling, looking for atrophy, ballottement test. That's basically, or a bulge sign. That's basically what I was saying. Like if you're feeling the knee and you palpate, like if you push down on the kneecap, you actually will feel it kind of bobble a little bit. It's hard to explain. You have to feel it to know. But compare sides because that'll tell you, like you'll see one side looks much more bigger than the other, and you wouldn't notice it until you look at both legs. Obviously, look at range of motion. That's a big thing. I just put these on. I highlighted like McMurray's test is for, and you probably remember these from your assessment class, or you should remember them. If not, just look them up. But McMurray's is for meniscal tear. So that they may have pain with movement or that clicking, and that is more suggestive of meniscal tear. So at that point, those patients, if you're or if they have signs and symptoms of a tear, then you want to get you want to get an MRI on the patient because an X-ray is not going to really show you much in terms of tears or anything like that. Mm. An anterior drawer test, Lockman test is for ACL, posterior drawer is for PCL. So remember those. Those are the very common ones. And then you have valgus stress and varus stress for your MCL and LCL. So those are like the ones that you typically do to look at the ligaments there. There's other tests too, but those are the big ones that I would say that you definitely need to make sure you know. X-rays, again, you want to do AP lateral. Sometimes we'll do sunrise or merchant views, and that's usually to look at the patella or like any patellar disorders. Because sometimes people will have actually arthritic changes under the patella. So it's a good way to look at it as well. MRI, I already mentioned, is good for looking at soft tissues, ligaments, meniscus, etc. Blood work, I kind of already went through that. So these are kind of like repetitive in terms of the things that I already talked about. Differentials by different locations. Patellar femoral pain syndrome, that's super common. You'll see that a lot, and we call it runner's knee. Patellar tendonitis is jumper's knee, and that you'll see kind of at the base of the knee. And they actually will usually have tenderness there, or if they have impact on it, they'll feel pain in that area, like at the inferior portion of the patella. And then obviously too, I'm just going by like lateral, posterior, medial, things like that. You can look at differentials for that as well. Red flags is kind of the same type of red flags I already mentioned before: fever, swelling, redness, locking, instability. And then obviously treatment's very similar to what I already mentioned in terms of conservative treatment. Braces, orthotics, NSAIDs, PT, rest, ice, compression, elevation. Those are all critical. Steroid injections for arthritis or bursitis. Obviously, like I already mentioned, there's a limited amount of times per joint per year. Hyaluronic acid injections are another good alternative, and you normally contain hyaluronic acid in your knee, and it's actually like a joint lubricant, so it does have a good result and not effect on the joint. Versus like a steroid is not that great, and it doesn't promote the health of the joint. Over time, it actually degrades it more. Those are good for quick pain relief and to kind of get things calmed down. But when the hyaluronic acid is like it's almost like putting oil in your car or in your joint. It basically provides lubrication to the joint and extra cushioning in there. So those are indicated for the knee, and patients can get them every 6 months, and they're weekly injections. It depends on which one they're on, but some of them are 3, some are 5, and they get like you can get them every 6 months typically, but some people get them once a year, and then you just continuously get them, and it kind of keeps their knee stable, or they don't have a lot of arthritic pain, and it's usually pretty beneficial for that. There is platelet-rich plasma, and I kind of talked about this a little bit before. It's typically not covered by insurance, but it's the same type of thing. It has a lot of growth hormones that will help with like the inflammatory process and healing. Sometimes we'll do that after certain surgeries and ortho. Like I've done them in the knees before. Some people haven't done it in the shoulder. We also will drain the knee if they have an effusion, because if they have a lot of swelling in the knee, if their knee is really swelled up, they will have a lot of pain there, and they will have very limited range of motion. And a lot of times after you drain it, it feels way better. So you can refer them on to ortho to get it drained. And at that time, usually they'll give them like a steroid injection with it. Like they'll drain it and then do a steroid with it. So that's like a good option for that. Arthroscopy, we do a lot of that now. It's obviously less invasive. It's usually more for those tears, cartilage repairs. And then obviously if it's advanced, then they're looking more at like replacement options with that as well. In terms of the shoulder, this is just the same exact thing that I kind of went through with the other joints. It's the same thing, like using NSAIDs, checking the range of motion, looking at diagnostic testing, what makes it worse, what makes it better. It's super common for patients to have rotator cuff injuries, so that's one thing that you'll see a lot. And then the other end of the spectrum is even like arthritic changes where patients will actually have to have like a total joint replacement in their shoulder. It's less common, but can definitely happen. So when you evaluate it, it's the same exact thing, systematic approach of getting a thorough history, physical exam, and appropriate diagnostic testing. So you want to look at things have any trauma, overuse. Do they have osteoarthritis in general? Do they have any referred pain? Because sometimes shoulder pain can actually be coming from the neck or the spine, essentially. And it may feel like shoulder pain, but it's actually coming from the neck. So you really got to look at that as well. So again, inquire about any numbness, tingling in the shoulder area, the forearm, the hand, anything like that as well. And then by location, like anterior, you can have rotator cuff tendinopathy, bicep tendonitis, lateral rotator cuff injuries. The biggest thing that you'll see is rotator cuff injuries. And a lot of times you have to get an MRI, start with an x-ray, but then get an MRI to determine if there's any tears there. And again, this would be a referral to ortho for treatment and management, essentially. These are just different associated symptoms. And then if you look at it by age, like young adults, it could be young adults, it could be like a labral injury. Middle age, you see a lot of rotator cuffs in middle age. And a lot of times it's related to overuse or like the work that they do. Same thing with older adults, you see a lot of arthritis and rotator cuff tears as well. So look at occupation, sports, look for any history of trauma, systemic conditions, etc. So it's a lot of the same concepts that are kind of presented with the other joints as well. And obviously look at the neck too to make sure there's nothing coming from there. So these are other areas. Look, do active range of motion, passive range of motion, strength testing. So look at strength of their deltoid. Look at movements of being able to rotate the arm behind the back, across the chest, things like that, because that'll help you determine if there was any impairment with the rotator cuff as well. Assess for any warmth or swelling, obviously, because that would be an indicator of infection or inflammation. The other thing too is, again, look at muscle mass. So you really want to get a good look at the patient and compare sides. Sometimes you will see scapular winging. And if you were to Google it, you can literally look up scapular winging. And the scapula will actually be tipped on one side of the back. And that's because of it can be from spinal issues, like from a nerve issue in the back, or it can be related to rotator cuff. And then they start to because they get atrophy and imbalance in the musculature there. So they get scapular winging. So if you look it up online, you can see an image of it. But that I've seen before a few times. So that's why I'm always saying, like, look at both sides. In ortho, you definitely want to look at both sides and compare and do like a thorough exam. In terms of rotator cuff, like special tests is like the drop arm test, Near's test. I'm sure you remember those your physical assessment class. If not, just look them up again. Those are the two that you commonly see, or apprehension test. You'll see that too. Again, X-ray, MRI, same type of diagnostic studies that you'll generally will go to in terms of approaching diagnosis. Red flags, again, very similar. Fever, warmth, erythema. We worry about septic arthritis. Night pain, we worry about malignancy. And it's not, in a lot of patients with shoulder issues, they wake up in pain because you sleep on your shoulder. So that's not uncommon with arthritis or rotator cuff tears. So it doesn't necessarily mean that it's malignancy or infection if they wake up at night with shoulder pain. A lot of times it's because they're just laying on it, and that's pretty common. So, but you want to assess for that. Obviously assess for acute trauma, look for cervical radiculopathy. So again, any numbness, tingling, weakness, anything like that, that would indicate a nerve, an issue with their nerve. And then at that point, like I said before, you can even do like an EMG study to determine whether it's like a peripheral nerve that's causing an issue or if it's coming more from the spine. If you are suspicious of the spine, then that's when you would want to obviously do like a cervical MRI too. Usually you have to do an x-ray first, but then you would move to like an MRI of the cervical spine. Again, conservative treatment, same exact approach. NSAIDs, RICE, PT. PT is so important now because if you don't have good range of motion and you don't have good muscle structure around your joints, supporting that joint. It just they're set up for having more pain and less support around that knee joint. So PT is really critical for obviously for ortho stuff. Activity modification, like avoiding aggravating movements, things like that. Steroid injections are commonly used. PRP can be done. It's not indicated, but I have seen hyaluronic acid done for shoulders. It's the same kind of concept that you would do with the knee. And then if there's an effusion, sometimes they'll drain it too. This is all done by ortho though, so you would have ortho do that. In terms of sprains, strains, and fractures, obviously super common. Sprains basically result from a stretching or tearing of the ligaments that bind the joint from bone to bone, as the joint is forced beyond its normal range of motion. So it's pushed beyond that normal range of motion, and it's the ligaments that are from bone to bone, and then obviously it can cause swelling and muscle spasms around the area as well. Where strains result from stretching of ovaries of the muscles and or tendons, so muscles to bone, and they can have swelling, discoloration, pain with movement. So those are like the small differences that you kind of use as descriptors between the two of a sprain versus a strain, essentially. Super common. Unfortunately, sometimes sprains and strains can actually pose a patient a lot of problems. Like they can have partial tears even from it. So they can suffer, even though it's just, you say, oh, it's not a fracture, it's just a strain, but sometimes, or a sprain, but sometimes they take a while to recover from. So they can be, they can take a while to heal, unfortunately. So dislocation is exactly what it means. I'm sure you kind of already know what this means, but it's the articulating surfaces, basically, they slide out essentially. And if it's partial, it's called a subluxation. Fractures, obviously a fracture, I think you guys know what fractures are. Obviously, if they're closed versus open, puts them at higher risk. If they're open, higher, if it's open, then they're higher risk for infection. In terms of sprains, so they're usually one of the most common injuries that you'll see, particularly in athletes or active individuals. It's really evaluating the severity of the injury, making sure that they don't have a fracture, and then trying to figure out what structures are actually involved in that strain. But obviously, they tend to have a lot of swelling, bruising. They may feel like it's going to give way, or they feel like their joints unstable. Most of the time, they have difficulty bearing weight on that extremity or the ankle. I mean, risk factors, previous ankle sprains. A lot of times, people who get one ankle sprain, they're at higher risk for another one. Actually, it's because it becomes weakened over time. So that's why therapy too is another big measure that you need to ensure your patient's doing, because they need to strengthen the ankle and surrounding muscles and ligaments there. Inadequate warm up or certain footwear obviously can trigger it as well. Sports that have jumping or rapid directional changes, so if there's rapid movements, they're at higher risk for having ankle sprains as well. Any red flags in their history, like they had significant trauma, like a fall from a height, obviously in something like that, you would be worried that there's a fracture there too. Persistent pain despite treatment, pain beyond the ankle, things like referred pain or any other potential injuries that are going on with the patient as well. So in terms of your exam, obviously you're going to look for swelling, look around the lateral malleolus, look for diffuse swelling in the area, look for bruising. Is there any deformity in that area that would suggest fracture or dislocation? You really do, most patients complain, but you do have to palpate over specific ligaments. So palpate just anterior to that lateral malleolus, below and posterior to the lateral malleolus. And I don't mean to like get off track, but I put, there's the Ottawa ankle roll. I put it up on our Moodle site. It's a good way to approach an ankle injury and whether you need to do imaging on it. And it shows you the exact anatomy of where you need to look in terms of like palpating and looking for ankle pain, and when you image an ankle essentially for an x-ray to make sure that it's not fractured. So make sure you take a look at that. I think I even have it on the next slide. Range of motion, it may be very difficult to assess this in the patient because they may have a lot of pain with it. But you do want to try to assess some whether that you can get some active or passive dorsiflexion, plantar flexion, inversion, and eversion. So it's basically like all four motions that you're trying to check. And usually it's obviously more bothersome one way versus another, depending on how they sprain their ankle. Um, if they have a restricted range of motion, they usually typically have fluid there, a ligament injury, or like a joint infusion going on. Strength testing, you do want to look and make sure that they still have strength there. Do they have strength on dorsiflexion, plantar flexion? So have them push against your hand, push their toes up against your hand, and then obviously inversion and then eversion against resistance as well. If they have significant, it's not uncommon for them to be a little bit weak at the very beginning because it's painful and it's just they're not putting as much effort into it. But if they have persistent weakness there, then it's highly suspicious of a ligament injury, which could be a partial tear essentially or a tear in the area, which would warrant further imaging, usually at that point in MRI. Oh, I do have it on here. The Ottawa ankle rule. So this is and then I added it on our Moodle site or our Moodle site, and there's a document up that I put up on there in terms of when you would do X-rays essentially. MRIs when you are suspicious of like a ligament tear or any cartilage damage essentially. And then there's different grades that you can grade the ankle sprain based on. So grade 1 is mild. They would have like a slight tear of the ligament, very minimal swelling and tenderness. So those are very mild sprains. Moderate would be like a partial tear. They have moderate swelling, bruising, and pain with weight bearing. So at that point, it's difficult to bear weight on it. Grade 3 is when it's very severe. This is usually obviously when they have like a complete tear. They can't bear weight on it. So that you absolutely need to have imaged with MRI to see exactly where it's torn or if it's completely torn essentially. So it's the weight bearing that you have to really look at. So for that acute first 48 to 72 hours, it's the RICE protocol. So rest, avoid weight bearing on the affected ankle. So you don't want them bearing any weight on it. Ice 20 minutes every 1 to 2 hours to reduce that swelling. Compression. So whether you have them use like an ACE wrap, an ankle brace, and then elevate it too, because obviously that'll help with the swelling as too. Pain management is NSAIDs and or acetaminophen. In terms of fractures in ortho, you want to stay away from NSAIDs. NSAIDs can inhibit because it's the inflammatory response, bone regrowth. So if there is a fracture, you want to stick to things more like Tylenol. But if it's a sprain, you can use an NSAID essentially. So obviously you want to refer to ortho if there's no improvement in that first 48 hours essentially, or if you suspect a fracture or a tear. If you think that they need an MRI, you're definitely just going to send them on to ortho for a workup essentially. In terms of education, it's proper warm up, stretching before activities, strengthening those ankle stabilizing muscles. So a round of PT would definitely be beneficial for these patients. Appropriate footwear, supportive braces. And then obviously if there's, like I noted at the bottom, immediate emergency referral for injuries that show neurovascular compromise, penetrating object, a wound, or those that have a crush injury or result in open fracture. So those are obviously ED referrals right away. Elbow pain is pretty common besides bursitis. The other two that you commonly see is epicondylitis, lateral and medial epicondylitis. So those are the two that you definitely need to know. This is kind of the same exact thing that I went through with every other joint in terms of the approach, diagnostic studies, like what to do in terms of like RICE, NSAIDs, things like that, PT, OT. And then I'll go through some more specifics with you. So lateral and medial epicondylitis are very common. I put some articles up on our Moodle site as well, so take a look at those. It's known as golfer's elbow and tennis elbow. So medial is golfers, lateral is tennis elbow. And usually it's common overuse injuries of the elbow by repetitive strain on the tendons in that area. So obviously proper evaluation is critical for diagnosis and management, but it's very, very common. So obviously you inquire about the activities that they partake in, their occupation as well, because that obviously can put them at risk as well. So with medial epicondylitis, they'll have pain on the inside of the elbow, and it often radiates down the forearm, where lateral is pain at the lateral or the outside of the elbow, and it radiates down the dorsum of the forearm. And usually, if you were to palpate over the epicondyle, like whether it's lateral or medial, they'll have pain and tenderness in that area. It does have a more gradual onset because it's usually related to overuse. So it kind of comes on over time. And sometimes it waxes and wanes. Like it may get a little better and then they start to overdo it and it gets worse again. It can be more acute if it's related to a very specific trauma or severe strain or something that they were really they really aggravated it. But usually it's more gradual. They tend to get it. So medial, it's a lot of times it's associated with activities involving wrist flexion and pronation. So that's why it's like you'll see it with golfing, pitching, carpentry. Those are things that you'll see that medial with. Lateral is usually more with extension and supination. So things like typing, tennis typing, repetitive gripping. So you'll see that more with the lateral. So that's why you want to inquire about like some of the activities they partake in, hobbies they do, what they do for work, things like that. And then obviously do like a good exam on it. In terms of functional impact, it can definitely cause issues like difficulty gripping objects or performing tasks that require forearm strength, because that actually, if they start to do that, it actually will cause pain in that area. And then the pains are even more exacerbated by some of these repetitive movements as well. Other risk factors, so occupations, I already mentioned some of this, like manual labor, computer use, sports with repetitive, like tennis, golf, mentioned it, poor ergonomics, poor or improper texture, improper technique. I already mentioned where you would feel palpation, you would have tenderness over the areas. You may have some mild swelling in the areas. Range of motion is typically normal, but it usually will elicit that pain. So they may have normal range of motion, but then they're going to kind of complain that it actually will hurt. So pain with resistive wrist flexion and pronation. So if you were to have them flex the wrist up and like flip it up, that's where they'll tend to have more pain with medial epicondylitis. And then if you have wrist extension and supination, it's more with the lateral epicondylitis with that. So like those are different range of motion tests that you can do or elicit to see if they have pain with it. You do want to test their strength as well. They may have weakness in that grip strength because it's painful in that area as well. So then their grip is not as strong as it used to be. Pain during resistive finger and wrist movement. So that's where you're kind of getting where that with wrist flexion and extension and supination, pronation, and also with the wrist finger movements, you can sometimes have pain with that as well. Imaging is generally not necessary for this. Usually you can tell based off of their exam. Obviously, if there's red flag symptoms there, heat, worm, signs and symptoms of infection or something else going on, then obviously progress forward with x-ray and then MRI. And again, a lot of it is the same approach to treatment. It's NSAIDs, rest, ice, elevation, compression, avoiding repetitive movements. So it's really big to educate them on avoiding those activities that aggravate it, because a lot of times they continue to partake in the same activities over and over and over. And it's very difficult to get it to heal or to kind of get them out of that flare up unless they kind of slow down in terms of those aggravating activities. For medial epicondylitis, you can give them some stretches, like the wrist extensors. For lateral, it's the same thing, but stretch with flexors. And they have a lot online. Like if you were to look up stretching exercises for lateral epicondylitis, you can even print them off for your patients. Stretching exercises for medial epicondylitis, and you print them off for your patients and you show them, and you have them do them, like reps of 10 times 3 and have them do it 2 to 3 times a day. So those definitely help too, because it kind of helps loosen up the forearm, the ligaments and all that in the area. You can have patients get corticosteroid injections. Some physicians in primary care will do them. It just depends on if they're comfortable with it. If not, obviously ortho definitely would do a steroid injection as well. Hand and wrist pain is another thing that you'll see, obviously, too. The big thing is you want to make sure that they didn't have any accidents or injuries or falls, because you don't want to miss any fractures of the hand. Because obviously, fractures of the hand, you worry about healing and use of their hands, whether it's their dominant or non-dominant hand. But also look at other factors like systemic symptoms, like those things like we talked about, like RA or lupus, things like that, because they could have a systemic disorder going on that's causing them to have hand or wrist pain. So is it bilateral hand pain or wrist pain versus one or unilateral, essentially? Is it with overuse, or do they wake up that way? Obviously, the diagnostic testing is very similar: X-ray, MRI, ultrasound, etc. And the same thing in terms of management. We'll kind of go through this as we move through each different things. There are some must not miss hand fractures, and I think I have it on the next one. But the big thing is when you have like a direct blow or fall into an outstretched hand, they're at high risk for hand fractures, and those are ones that you don't want to miss. So you got to be cautious. If your patient, hand things are just something you don't want to miss, because obviously you use your hands for everything, and it can be detrimental in terms of healing. And then there's some bones that don't have great blood flow to them, so the healing can be impaired as well. So I would say, to be cautious, I would automatically like get an X-ray if someone like had a fall onto their hand, or obviously a injury, or even like a twisting of the wrist. I would definitely get an X-ray of it. You also want to make sure that they don't have any numbness or tingling, so any neurovascular compromise, any weakness there too, because sometimes if they have weakness, it can be related to a tendon injury or a nerve injury as well. So look at things like the gripping, like are they able to grip things? Like, do they have good range of motion of their fingers? Do they have good sensation of their fingers? Things like that as well. Look for obviously physical deformities, swelling or bruising, open wounds. Remember, with any open wounds, you always want to make sure, this is just like a little side tidbit, make sure your patient's up to date on their tetanus shot as well. Palpation, you want to palpate over the bones to look for any tenderness over specific joints. Look for crepitus, instability, any deformities that you note. Active and passive range of motion. Neurovascular assessment. You want to make sure that they, look for nerve injury, like whether it's median nerve, ulnar nerve, radial nerve. Look for perfusion, check obviously their pulse in that area as well. It's the scaphoid fractures, the one that I was mentioning before. This is one of those do not miss fractures of the hand. And it's usually pain with axial loading through the thumb, and it can suggest a scaphoid fracture. And the big issue with it is that there's the blood flow to it is limited, and they're at higher risk of avascular necrosis to that actual bone. So it's one of those that you absolutely are referring to ortho. Any wrist injury or hand fracture or anything like that, you're going to refer to ortho. But usually with the scaphoid fractures, a lot of times it's one of those foosh, like so the fall with the outstretched hand, with the wrist hyperextended, and then they'll have pain in that snuff box. So a lot of times if you feel their hand in here, they'll have pain there too, or tenderness with wrist movement. So initial X-ray is what you would do. But if you're suspicious of a scaphoid fracture, you absolutely need to move to an MRI, because X-rays can often be negative. So with the hand, you want to be very diligent and don't be afraid to order an MRI on the patient, essentially. So as I mentioned, PA lateral oblique views of the hand include scaphoid views. If you feel like that's a suspected fracture there, like you want to write that on your ordering report for the radiologist to note. That way they look at it in particular, and then usually they'll recommend, MRI indicated, because we can't get a good view of the scaphoid. Usually the radiologist will kind of give you like the next steps in line in terms of if they couldn't tell based on the initial X-ray. But MRI is always another good thing that you want to look for in terms of for the hand. Ultrasound is not done that often. But like sometimes in some cases, ortho will use it, like if they are suspicious of a stress fracture and they want to look at it in the office. A lot of times orthos have ultrasounds in the office and we just use them in that for that mechanism essentially. Immediate care is obviously immobilization. So they're going to splint the area to prevent further injury. Pain management, NSAIDs, acetaminophen, urgent referral to ortho for open fractures, significant deformity or neurovascular compromise. Honestly, any hand or wrist fracture, send to ortho because that's something that you want them to heal well with, obviously. Carpal tunnel super common. I'm sure you guys already know a lot about this, but obviously with carpal tunnel, it's entrapment by compression of that median nerve. And a lot of times it's related to like repetitive motions of the hand. So assess their occupation, hobbies, etc. But their symptoms tend to be that pain, paresthesia, weakness, or nocturnal symptoms where they wake up at night and their hands hurt, or they wake up and they're completely numb. And a lot of times it's because of the way you sleep at night. You sleep with your hands flexed like this. A lot of patients do. They wake up and then they can't feel them and they're numb. It's very common, unfortunately. And a lot of times we use splinting. So you can order your patient wrist guards, like they're more firm braces that they would wear, especially at night. Mainly at night, they definitely should be wearing them because that's when a lot of time it aggravates it when they're at night when you're sleeping. But they can definitely wear them during the day too because it kind of keeps them more aware of the things that they're doing, and then it does help keep their wrist straight. Um, and it doesn't aggravate that nerve essentially if they're keeping it with a brace. So you can do that. The other thing too is sending them off to ortho and they'll do injections. So they can do corticosteroid injections into the area around the median nerve. In severe cases or refractory cases, they can definitely do surgery on it as well. So it kind of really depends on how bad it is, and how severe, how disabling it is to the patient. Sometimes it can be pretty severe, but it's education too, like a lot of typing, a lot of vibrating tools. So you'll see it like with machinery, things like that, or people who work out a lot and they're using repetitive wrist movements. Um, or you'll see patients kind of go like this with their hands and they're trying to get the feeling back into it. You can see it more commonly with things like rheumatoid, hypothyroidism. It definitely gets worse during pregnancy, and that's usually related to just the swelling and fluid volume. It just puts more pressure on that nerve, essentially. So it's not uncommon to see it actually get worse. I'm sure you remember from, I keep saying patho, from assessment, the Fallon's test and Tinel's test. So those are the two tests that we use for carpal tunnel. Make sure you know those. It's going like this, and then obviously tapping over the median nerve at the wrist. And then obviously they'll get positive symptoms when you, or reproduction of those symptoms when you do those two tests. So those are two that you need to know. Look at grip and pinch strength as well, because they may start to get more weakness as it progresses, essentially. So you want to make sure that they're not getting that. If they're having weakness in the area, they definitely need ortho consultation. You can do an EMG test if you are not exactly sure where it's originating from. It's usually pretty easy to pinpoint based on your Fallon's and Tinel sign, but you can do an EMG. Sometimes physicians or providers will ultrasounds to actually look at that median nerve to see if there's any swelling around that carpal tunnel area. The other thing too is sometimes there's ganglion cysts in that area that actually could be putting pressure on the nerve as well. So you can identify other external factors besides just inflammation in the area. In terms of differentials, again, think about the neck. So always think about with any joint pain, leg pain, hand pain, arm pain, always think about the spine. Because remember, obviously, it's your sensory nervous system. So you can have radiculopathy that you actually think the patient might actually think that is like from the ulnar or median nerve, but it's really coming from their neck, from C6 or C7. So always assess about neck pain, or if they have higher up pain, not just in the lower forearm, because obviously it can be coming from higher up, and that's when an EMG is very helpful because it'll help tell you where that neuropathy is actually originating from. And then obviously if you're very suspicious of cervical radiculopathy, you want to do an MRI of the neck. as well. Activity modification is huge. You have to make sure that they're understanding what is causing these flare-ups, and trying to get them to kind of cut back on some of those activities that are making it worse. Splinting is critical, so especially night splinting, and it keeps that wrist in a neutral position as well. PT sometimes helps, sometimes not that helpful, but you can definitely try it in your patient. NSAIDs, maybe slightly beneficial. Corticosteroids for more moderate cases or moderate to severe cases, they actually work pretty good. It's time limited. And if they go back to the same activities, a lot of times those steroid injections wear off and they end up right back where they started. So um, that's why it's really critical to educate them on like things that the activities that they kind of have to make sure they're staying away from, and then making sure that they're actually wearing splints as well. And then there obviously more advanced management would be like a carpal tunnel release for refractory cases. And obviously that's for those patients that kind of have unrelenting symptoms despite other therapy or treatment. Okay, so that was it with this PowerPoint. I'm going to go and I added a bunch of resources in terms of like ortho stuff from some of the other books that I have. Just take a look through them. I think if you read through there's some images in one of the other, some files that I added, and I think it helps make sense when you actually look at the pictures with it too, as well. So let me stop sharing and I will get the other ones recorded for you. I hope you guys are doing well. Thanks.